Early class 2 diagnosis and management. I'm Dr. F.S. Nkhumeleni, an orthodontist. I did BDS in 1989, MDS in 1995, and MDent also in 1998. I have both experiences in academic and practice world. I'm currently practicing in Pretoria mainly and Polokwane. Class 2 Division 1 and 2 needs to be diagnosed before the age of 12. And this is particularly related to growth and growth spurt. Cardinal signs of Class 2 Division 1 are enlarged overjet, underdeveloped mandible, or overdeveloped maxilla. Class 2 Division 2 has retroclined anterior teeth, both upper and lower anterior teeth, and Class 2 molar relationship, which may not show underdeveloped mandible. Retrusive chin is also a common phenomenon in both. Patients with Class 2 malocclusions, especially Division 1, are perceived as stupid. Class 2 Division 1 is associated with habit, which could be a primary habit or secondary habit. Primary habit is you start sucking your finger and then the upper jaw overgrew the lower jaw. Or secondary, your jaws are not meeting together, then the patient can start sucking the lower lip, making the upper jaw to protrude even further because the lower teeth will retrocline and lower jaw will be underdeveloped. There is also a genetic component in this, so it could be from a parent or both parents, even some few relatives down the line. Ironically, most beauty pageants are Class 2 Division 1. The early management goal is to convert both Division 1 and 2 and together with Class 3 malocclusion into Class 1 malocclusion. Based on the growing deficient jaw or restraining overdeveloped jaw, and also you could redirect growth of the overdeveloped jaw. Both Class 2 Division 1 and 2 are managed differently. Class 2 Division 1 is mainly by growing the deficient jaw by a functional appliance and or restraining the underdeveloped, rather redirecting growth of the overdeveloped jaw. Class 2 Division 2 must be converted first into Class 2 Division 1. Class 2 Division 2 need to have fixed braces first so that you could align the retrocline incisors, which are locked in place. And then the conversion will now be Class 2 Division 1, which you can use a functional appliance if there is a deficient jaw afterwards. Skeletal changes, if it has to be successful, should be before the age of 12 or by the age of 12. And that's when you get the most growth of the deficient jaw. The subsequent profile improvement, retention is required by wearing the same or modified appliance. Changes could be permanent or complete, else could be a partial change. A partial change, meaning more than 100% change, will make the surgical correction later in life a lot easier. Failure to improve the profile due to no treatment or failed treatment can be resolved by surgery only from the age of 18 onwards. Early management of class 2 malocclusion is so-called phase 1 treatment, which is usually followed by phase 2 treatment. Phase 1 treatment is based only on the growing of the underdeveloped jaw, and phase 2 involves the crooked teeth or malaligned teeth correction. Headgear has been used for many years to redirect or restrain the growth of the overdeveloped jaw. Functional appliances, which are many different types, are used to encourage the lower underdeveloped jaw to grow, to catch up with the upper. I tend to use a twin block. All functional appliances act basically in the same way. The idea is to protract the lower jaw forward, and by doing so, a few things happened which results into growth of the lower underdeveloped jaw. Research unfortunately can't pinpoint exactly what happens, but there are three possibilities. Number one, there is condylar growth. In other words, the condyle grow upward and backwards, which tend to push the lower jaw forward. The second possibility is the fossa, where the condyle, the head of the condyle sits, descends. In other words, the fossa descends, so it goes down. If it goes down, it will force the lower jaw to go forward, or any of the above. Okay? Phase 1 treatment in growing patients is basically from mixed dentition. That's the stage where you still have both primary and permanent teeth at the same time. Success is based on the cooperation of the patient, as unfortunately the patient has to wear the appliance. As I said, there are many different types, but it's best to stick with one type so that you can perfect its use, and also for your lab technician to perfect its manufacturing process. Untreated class 2 cases during phase 1 tend to persist. In other words, they're not self-corrective. They can't correct themselves without a treatment. As well as phase 1 failed phase 1 treatment. So you can fail to effect the change. So if that happens, two things can be done to remedy the situation. You could have a compromised treatment where the deficiency is moderate to mild by removing upper two premolars, or a surgical correction where the jaw which is deficient will be surgically moved forward or backward to align with the correct jaw. Converting class 2 division 2. This unlocks the malocclusion, which tend to affect the condylar sitting as well. Firstly, fixed orthodontics is done with or without a functional appliance. It is possible to do both phase 1 and phase 2 separately or together in both division 1 and division 2. Oh, thank you. The message of this lecture is diagnose your patients earlier. Diagnosis will mean you need to have a ceph and a cephalometric tracing, which will show you the relationship of the upper and lower jaw. If you remember the figures, the A and B, which is the difference between S and A and S and B, it has to be 6 or more than 6 degrees. There are other features, as you know, on the cephalometric tracing, which will guide and confirm the relationship of the two jaws. If you can't figure that one out, you could refer that to an orthodontist who can help you confirm whether the patient has a class 2 malocclusion or not. It is also imperative that you do find from the parents if any of the parents has the same condition, because if the condition is in the parents, you are unlikely to succeed with what you're trying to do, as the genes will have to fully express themselves. In this case, the treatment will be surgical correction of the deficiency. Thank you.